Okay, welcome everyone. My name is Amelia Ventura and I'm a Master's in Public Health student at Liberty University, and I am currently finishing up my Public Health Practicum. My emphasis for my degree was in health promotion, and my practicum focused on sexually transmitted diseases, and basically I did a quality improvement project for the clinic that I was working at Children's of Alabama. So a little bit about the adolescent clinic. It's a primary care and subspecialty consultation for adolescents aged 11 to 21. They provide comprehensive health assessment, care of all of their acute illnesses, minor traumas, immunizations, family planning, acne, STD prevention, management, treatment, as well as menstrual disorders and things of that nature. It is funded by the Title V block grant under Maternal and Child Health, and I had the opportunity to shadow a lot of physicians, social workers, public health specialists, and clinical assistants, and I was able to see many patient intakes, exams, diagnosis, treatments, educational sessions, in addition to the types of educational handouts that they have available to their patients. And then, like I briefly said, main project I worked on was a quality improvement project, an STD quality improvement project, and I also did one regarding asthma. However, I chose to focus on the STD quality improvement project for my paper and for the remainder of this presentation. So quality improvement is a systemic and formal approach to the analysis of practice performance and efforts to improve performance. The model that Children's of Alabama, and specifically the Adolescent Health Clinic, uses is the PDSA, Plan, Do, Study, Act model. And involves many different cycles. It's a continuous thing that can always be adapted and changed to continue improving. So just a little bit about STDs and why they're a problem, and why the Adolescent Health Clinic chose to spend time and effort doing a quality improvement project on it. So as we know, they're a major health concern in the United States. There's more than 2 million cases of chlamydia, gonorrhea, and syphilis, and that was in 1 year in 2016. And a majority of those tend to be patients in that adolescent age. There's many reasons why this could be. Behavioral, biological, and cultural reasons all play a big role. Adolescents face a lot of challenges accessing the quality prevention and management services. Sometimes they can't pay, maybe they don't have a way to get there, so lack of transportation, long waiting times, clinical hours that conflict with their school or maybe possibly their work schedule, in addition to the embarrassment that might be attached to seeking help for an STD. So majority of patients in this clinic are there for reproductive visits, whether they're there for just their annual exam, whether they're there for a pap smear, a concern for an STD or a urinary tract infection, or maybe they have irregular menses or are looking for some type of birth control. So as we saw, those are astonishing stats regarding the number of individuals that are diagnosed with STDs each year, majority of them, like we said, being in that adolescent age. And so this is a really good time to teach adolescents about STDs and the effects. So just a little bit more about each of the 3 main STDs that we're going to focus on for this quality improvement project. And that's chlamydia, gonorrhea, and trichomonas. So chlamydia is the most common STD. It's an obligate intracellular bacteria that can cause pneumonia, conjunctivitis, urethritis, reactive arthritis, and more concerning, pelvic inflammatory disease, because that is a negative health consequence of untreated chlamydia. Gonorrhea is a gram-negative diplococci bacterium and can cause septic arthritis, neonatal conjunctivitis, pelvic inflammatory disease as well, just like chlamydia, and Fitzhugh-Curtis syndrome, which is like a perihepatitis. And gonorrhea tends to co-infect with chlamydia, and both of those, like I said, that pelvic inflammatory disease and a few other problems, they they can cause lifelong complications. So it's very important that they do get treated for these diseases. And then trichomonas, it's a protozoal infection that usually causes vaginitis with itching and burning and a foul, green, smelly discharge. But it can also lead to something called strawberry cervix if it's untreated. The Center for Disease Control and Prevention does have strict guidelines set for the treatment of these diseases. Gonorrhea and chlamydia is a dual therapy, a single dose of intramuscular ceftriaxone, as well as oral azithromycin, and trichomonas is treated with metronidazole. And they do have also specific guidelines on recommendations that we should be making to these adolescents to ensure that they get completely cleared of the infection. So they should be instructed to abstain from sexual activity for 7 days after their treatment, and until all sexual partners are also adequately treated. They should be tested for other sexually transmitted diseases, the big one being HIV. It's also recommended that they notify their partner that they were infected so their partner can also seek treatment. And it's also really important that we retest them in 3 months to be sure that they have been cleared of the infection. So currently Alabama doesn't have very good laws and regulations and things in place regarding sex education. And, being a master's in public health and focusing on health promotion, education is a big key in order to help reduce the risk of infection and stress the importance of testing, diagnosis, and treatment. So sex education is currently not required in Alabama at public schools. And if it is taught, it has to meet such specific guidelines and has a focus on abstinence, that they don't really educate on really sex in general, pregnancy, or sexually transmitted diseases. So this is I kind of alluded to this earlier, but this is where the adolescent health clinic can make a big impact on their patients and the adolescents to ensure that they're properly educated. Education and counseling is a big part of each reproductive visit and a big reason for the need for this quality improvement project. So Cycle 1 was put into place by Dr. Tina Simpson, who's the principal investigator. It was implemented June 1st of 2017, and this is the Pareto chart from that cycle. And as you can see, the areas that fall below 80%, meaning that these would be the areas that are in need of most improvement, would be their return for 3-month follow-up appointment, partner notification, and HIV testing. So this cycle focused on physician documentation and attempting to get patients to come back for that follow-up visit. So what they did in order to try to aid in that documentation and getting people to come back was creating acronym expansions within their electronic health record system when they're doing their documentation, and those went into use starting August 1st of 2017 to help accomplish these goals. So on the next slide here, you can see that the acronym expansions are created specifically for each type of infection and included the treatment, that they should abstain from sexual activity for 7 days, that they should use consistent and correct use of barriers and teaching them what those barriers are and things that are available to them, in addition to giving them condoms or dental dams. Also encourage that they notify their partner within 60 days and that they also get tested. Also really important that we get HIV testing done, as well as trying to really get them to come back for their 3-month follow-up visit. So all of these are pretty much the same, just slightly different based on the treatment for infection. So on the next slide, you can see the trichomonas treatment and then another acronym expansion specifically for our medical assistants and nurses who might do some of the education or might hand them condoms. On this next slide, this is where I come in. This is the work that I did. So this is cycle 2, and this isn't the Pareto chart quite yet. This is just a yes-no bar chart from the data that I extracted. And how we went about this was we collected data by requesting it from the hospital analyst. And basically what we had to do is we went online, we filled out this very specific questionnaire and criteria. And the criteria we were looking for were patients that attended the Adolescent Health Center, ages 14 to 21, and they had to have an ICD-10 code meeting the diagnosis of gonorrhea, chlamydia, or trichomonas. And only patients that were diagnosed from June 1st of 2017 to January 30th of 2018 were included for this portion of the Quality Improvement Project. And exclusion criteria was anything that didn't meet, the criteria I just stated. What we then did after we got the data from the hospital analyst meeting those criteria is we selected 20 patients at random using a random number generator online, and we filled out a data extraction sheet with all the pertinent information it was that we were looking for by reviewing each patient's chart and a specific visit in which that they were diagnosed with one of those 3 infections. So some of the demographics for cycle 2, obviously we just said 20 patients at random. There were 19 females and 1 male, 10 African American and 1 white. 15 were diagnosed with chlamydia, 2 with gonorrhea, and 4 with trichomonas. And so a majority of the patients that we see in this clinic tend to be African American, and most of them tend to also be on Alabama Medicaid. So as you can see for this cycle, a majority of the patients that were selected at random were African American females on Alabama Medicaid that were diagnosed with chlamydia. So seen above in this yes-no bar chart, you can see that over half of the physicians didn't use those templates or acronym expansions that were created in cycle 1. Physicians did a pretty good job on their own remembering to discuss some of the pertinent health information regarding STDs. Less than half of patients that were scheduled for 3-month follow-up appointment actually returned for that scheduled appointment though. And those that did return to their follow-up appointment agreed to retesting. A majority of them were cleared from infection, but it's really important to get them to come back for that follow-up visit. So that was the main focus for cycle 2 and continuing forward, is trying to really come up with ways to get patients to come back. So this was our cycle 2 Pareto chart, and anything falling below 80%, those areas needing the most improvement, and those were the use of the created template that they created in cycle 1, and then getting patients to come to their 3-month follow-up appointment and need for repeat testing. So as you can see on this next slide, the recommendations made to the clinic staff would be the continued use of those acronym expansions. This really aids in reminding the physician what areas are most important to discuss with the patient. They get really busy from time to time, things might slip their mind, and so this template will kind of just give them a good reminder of every area that does need to be discussed with each patient. Making sure that they're placing an emphasis on returning for that follow-up visit is also really important. And a way that we tried to come up with really getting them to come back is collecting the adolescent's personal cell phone number to call back for both the results and for reminders. And we put this in the chart note on that visit that they were diagnosed with the STD. And again, also during that treatment visit, we're going to help them put the reminder in the calendar on their phone. I mean, all of these adolescents, or almost all of them, have a phone, and they're on them almost all the time. And they probably know how to use them better than we do. But so just, helping them put, or asking them, reminding them to put a reminder in their calendar on their phone regarding their follow-up visit and their retest appointment, hopefully that'll help remind them that they need to come back. And then also one thing I did notice going through some of it is a lot of times they were scheduled for their follow-up appointment from their diagnosis date rather than their treatment date. So we need to make sure that they are scheduling from their treatment date, their 3-month follow-up appointment, not the date they get diagnosed, because oftentimes there were quite a few days or sometimes a couple weeks before patients were able to come back in to actually get the treatment for their infection. And these are my references on this last slide. So overall, it was an excellent experience. Absolutely loved my practicum, and I think that it was a great way to really get my feet wet and see what it's like to be in a position providing, educational information to adolescents and just people of the general public, and using all of the knowledge that we've learned over the course of this degree. So thank you for listening. Does anybody have any questions?